So the first talk is going to be common problems in testicular pathology. So first, very simply, two common tumors, seminoma and embryonal carcinomas. Important to distinguish between the two because there are different therapies with each one of these. In the typical seminoma, usually it's pretty straightforward, clear cytoplasm, lymphocytic infiltrate, loosely cohesive cells, nice central nucleoli, fairly uniform cytology, not tons of mitotic figures. So again, usually not a problem. Some of the features you also see with seminomas often have little squared off shaped, not all of them, but some of them will have almost a little boxy shape to them, which is typical of seminoma as well. Where it can be problematic is there is a variant of seminoma, it used to be called anaplastic seminoma, also called high mitotic rate seminoma. We don't use these terms anymore. We just say it's seminoma because they behave stage by stage the same as kind of the non-such pleomorphic seminomas. But it's important to recognize that this anaplastic appearing seminoma exists because it does have overlap with the cytology of embryonal carcinoma. And it's just beyond the pale of what we typically think of the cytology for seminoma. We recognize we still have the sprinkling of lymphs, and that's nice central nucleolus, just more atypical cytologically. Another pattern of seminoma that's unusual are cords of cells, but that's acceptable. And maybe even more unusual, we can get this pseudoglandular appearance of seminoma, where the cells fall apart, kind of mimicking glands, hence more easily confusable between embryonal carcinoma. Another example of kind of pseudoglandular seminoma. Another pitfall with seminoma is it can have extensive pagetoid spread up the rete testis. And the rete testis is glandular, so when the seminoma cells go up the rete testis, they end up looking like it's a glandular lesion. But in fact, these are still preserved rete. They still have the architecture of the rete with just seminoma cells. And you can do a keratin stain. It would light up the preserved rete with the seminoma cells in between. In contrast, this is embryonal carcinoma. It's a primitive tumor. It's cohesive in contrast to seminoma. Cytologically, much more pleomorphic, have multiple irregular nucleoli, much more coarse, clumpy chromatin, a lot of individual cell necrosis, more mitotic figures. That's the contrast seminoma, embryonal carcinoma. PLAP I pretty much don't use anymore for the most part, but the two stains that could be helpful, CD30 is going to stain with embryonal carcinoma, will be negative in seminoma. Keratins, I'll mention there's a pitfall, but some seminomas can have some keratin staining, but embryonal carcinomas are diffuse keratin positive, whereas seminomas are negative. OCT4 doesn't help you because it's positive in both. C-KIT, I usually don't use that frequently, but that would be positive more in seminoma than embryonal. So again, as I mentioned, immunohistochemically, both of them are OCT3/4 positive. Seminomas C-KIT, CD30 for the embryonal. And again, typically seminomas are keratin negative, but sometimes you can see a seminoma with loosely keratin positive cells. And I've seen some cases where that's been more than just the focal keratin positive cells, yet still typical seminoma. So just